Welcome to The Explainer. Today, we are tackling something you are absolutely guaranteed to see in your career, the incidental pancreatic cyst. We're going to focus specifically on what you, as a trainee, really need to know about IPMNs and, most importantly, what to do about them.
So why does this matter so much? Well, it all starts with this number. Thanks to the incredible imaging we have now, somewhere around 40 to 50% of abdominal MRIs done for totally unrelated reasons will show a pancreatic cyst. It's just there. And that number, by the way, only goes up as patients get older.
And that's the million-dollar question, isn't it? You get that radiology report back, you see the finding, and immediately your brain has to start working. Is this a harmless, incidental finding we can ignore, or is this something that could turn into cancer? So today, we're going to walk through the clinical pathway that answers that exact question.
All right, here's our game plan. We're going to follow the same path you would in the clinic. We'll start with the finding, figure out how to classify it, put the main suspect, IPMNs, under the microscope, run through the workup, and then get to the final, critical decision.
So first up, let's just take a second to appreciate the scale of this. Why are we even having this conversation so often these days?
You know, it really boils down to one simple fact. Our scanners are just that good now. They're so sensitive that we're picking up these tiny little things all the time. In fact, these incidentomas now make up more than half of all pancreatic cysts we find, even more than the pseudocysts we see after someone's had pancreatitis.
Okay, so we've found the cyst. Now we're at our first major fork in the road. We have to sort this thing to figure out if it's something we can relax about or something we need to take very, very seriously.
You can pretty much put all pancreatic cysts into two big buckets. Over here on the left, you have your non-neoplastic cysts. Think pseudocysts. Generally, we leave these alone unless they're causing problems. But then, you have the bucket on the right, the neoplastic cysts, or PCNs. And this is the group we're hunting for, because these are the ones that can have malignant potential.
And when we zoom in on that neoplastic bucket, one type just completely dominates the picture. Just look at this chart of resected cysts. Intraductal papillary mucinous neoplasms, IPMNs for short, make up almost half of the total. So if you're dealing with a neoplastic cyst, there's a good chance it's an IPMN.
Right, so let's put our main suspect under the microscope. For you, as a trainee, really getting a handle on IPMNs is the single most important part of managing these incidental cysts safely and effectively.
So what exactly is an IPMN? Well, let's break down the name. It's a neoplasm, a tumor that grows with these finger-like or papillary projections inside the pancreatic ducts. And the key thing is that it produces mucin, this thick, gooey stuff that backs up and dilates the ducts, creating the cysts we see on imaging. And crucially, they have the potential to become cancerous.
Now, if you take away only one thing from this entire explainer, please make it this slide. This is the absolute game changer for management. You have to figure out if the IPMN involves the main pancreatic duct or if it's just in one of the side branches. This one detail changes everything.
And here's why that distinction is so critical. Look at the jump in malignancy risk. For branch duct IPMNs, we're talking about a risk somewhere around 20%. But for main duct, that risk skyrockets to nearly 70%. The reason is that the main duct is like a superhighway running through the pancreas. If malignant cells get in there, they have an easy path to spread. This one single factor drives the entire plan.
Okay, so we know what we're looking for. Now, how do we actually investigate a suspicious cyst and hunt for those signs of malignancy? Let's talk about the workup.
So the workup is a pretty logical, stepwise process. We always start with the best possible pictures, which for this is an MRI with MRCP. That's just a special type of MRI that gives us a beautiful roadmap of the pancreatic ducts. If that scan shows anything concerning, we move on to step 2, endoscopic ultrasound, or EUS. This lets us get an ultrasound probe right up next to the pancreas for an incredibly detailed look. And most importantly, it lets us stick a tiny needle in and get a fluid sample.
So throughout this whole process, remember your goal. You're not just trying to say, yep, it's an IPMN. You are actively playing detective. You're hunting for specific clues, specific features that scream high risk for cancer.
And these are the red flags you're looking for. Think of them in 2 tiers. At the top, you have the high-risk stigmata. These are the major alarm bells, things like jaundice, a solid lump growing on the cyst wall, we call that a mural nodule, or the main duct being dilated to 10 millimeters or more. Then you have worrisome features, things like the cyst being big, growing quickly, or having thick walls.
Finding any of these should get your attention, but finding one of those top-tier, high-risk stigmata, that really changes the game.
Okay, this is it. This is where the rubber meets the road. We've gathered all our clues, we've done our workup, and it all comes down to this one huge question. Do we take this out or do we watch it?
Let's make the first part of this decision really simple. If you've confirmed a main duct IPMN, you have to remember that 70% risk of malignancy. The conversation with that patient is almost always going to be about surgery, especially if they have any of those high-risk red flags we just talked about.
But for branch duct IPMNs, things get a lot more interesting. It's not so clear-cut. Here, we're doing a classic risk-benefit calculation. We have to balance that lower, but still real risk of cancer against the very significant risks of a major pancreatic operation. Our goal is to avoid surgery for the many who don't need it.
And this flowchart is a great way to approach that nuanced decision. Let's walk through it. First question, are there any of those major high-risk stigmata? If yes, the path leads toward resection. If no, you go to the next question. Are there any of the worrisome features, like a cyst bigger than 3 centimeters? If yes, that's your trigger to get that EUS for a closer look. And finally, if there are no red flags at all, then you can feel comfortable putting that patient into a surveillance program with follow-up scans.
And really, this quote just nails it. This is the tightrope we walk every single day with these patients. The whole point of this careful, stepwise approach is to find the needles in the haystack, the truly dangerous lesions, while protecting everyone else from tests and surgeries they just don't need.
So as we wrap this up, let's just take a quick peek over the horizon. What's the next big thing we're all going to be dealing with in this field?
Well, here it is. Our imaging technology is just going to keep getting better and better. And that means we are going to find more and more of these cysts, and they're going to be smaller and smaller. And that brings up the next great challenge. How do we get even better at telling the harmless ones from the ones that are going to cause trouble, so we can avoid overtreating people while still catching every cancer we need to as early as possible? Answering that question, well, that's the next frontier.